Good evening, everyone. I, Dr. Sarita Jaiswal, welcome you all to the session of Transplantation Trails. I had privilege to learn transplantation directly from Dr. Chakrabarti, and I thought that this treasure of knowledge should not be limited to him or myself. Hence, I requested him to start this program, which is called Transplantation Trails. We started this program during the pre-COVID era and have already covered the basic science of transplantation, particularly immunology part. However, after a long gap, we are again starting this program in continuation of that. Yes, COVID was one of the reasons for that. But before we begin, I would like to wish you all Happy Navratra. As you all are aware that goddess Durga killed Mahikashur and was called Mahikashur Mardini. So similarly, the aim of transplantation in malignant or non-malignant diseases is to kill the evil, that is cancer or thalassemia cells in this given phase. But before goddess Durga became Mahikashur Mardini, she was gifted different weapons to kill, to which she carried in her arms and won the battle. Similarly, to win the battle against the leukemia or thalassemia, the battle begins with the weapons of multiple drugs. However, the battle with hematopoietic transplantation begins with the conditioning, and today's topic is transplantation conditioning. I welcome Dr. Chakrabarti to this session, who I think does not require any introduction in this forum. So I welcome Dr. Chakrabarti. Sir, my request to you is take us through the history of hematopoietic cell transplantation conditioning and how it was conceived and how it took shape in the initial decade of transplantation in 1960s to 70s. Over to you, sir.
Yeah, thank you. Thank you, Dr. Sarita. And welcome, everyone. Happy Navratri to all of you. I have already discussed once about the history of transplantation in one of this forum, but it's a pleasure to do it over and over again, because it gives you a sense of groundedness, it gives you a sense of belonging. It helps you understand that how tough the journey was, what we are taking things for granted today, how different and difficult it was in those times. Now, on your left over here, you see a survival curve, which is something that if you read the Nobel lecture from Professor Donald Thomas, which was published in several journals at that time, this particular graph was there. So what you see over here is between 1969 to 71, 11 transplants for more or less terminal acute leukemia were undertaken. And this is the survival which was there at that time, which is basically one patient survived at 1 year. And you see the major mortality took place by 100 days. And the pattern was more or less same in 1972, when 22 patients had undergone similar transplant. 1973, when 23 patients underwent transplantation. The numbers surviving were a bit more. There were 6 patients surviving. But a year later, out of 14 patients, you see that, at least 8 of them were surviving at around the halfway mark. So this was the turning point of hematopoietic cell transplantation, 1974. By that time, a lot of people felt that it was a futile experiment. I mean, why the hell are they doing this? No one survives, yet these procedures are taking place. And mind you, hematopoietic cell transplantation was attempted for a long time before 1960s. I mean, for the last 50 years, means somewhere from 2010 on to, 1910 to around 1965, 200 attempts were made at hematopoietic cell transplantation, and not a single person survived. So a review of the data came out sometime in 1966 or 67, saying that it's a doomed procedure, it's not going to succeed. But Donald Thomas had a different idea. He and his, students or junior colleagues at that time, which included Frederick Applebaum, Rainer Staub, and all the stalwarts who we hear of nowadays, who are all in their 80s, I would suppose. They all got together and decided that, look, hematopoietic transplantation, that time it used to be called bone marrow transplantation. Bone marrow transplantation is not succeeding. So what's the point of keeping on trying it on ill and terminal patients? Let's go back to the drawing board and see where we are going wrong. And in that process, they selected, unlike in most experiments, that preclinical experiments are done on mice. They selected canine or dogs. And there were several reasons for it. I won't go into the details right now. But what they showed at that time was that, if a dog gives birth to some 11 or 12 littermates, if you take bone marrow from some and give it to others, there might be transient engraftment in some of them, but not all. And in the course of the decade of the 60s, Donald Thomas and colleagues, they figured out that there is something called dog leukocyte antigen, which is inherited from the parents to the offsprings. And subsequently, we knew that in humans to be the human leukocyte antigen. And they found that those dogs or puppies who were matched in the DLA, dog leukocyte antigen, they engrafted, unlike the others who did not have. But those engraftments were very short lasting. So they carried out a series of experiments with different doses of radiation given to the dogs who were subject to the transplant, starting from 2 gray to 4 gray to 6 gray to 8 gray to 10 gray. And they found that at the dose of 9.5 gray in dogs, engraftment was successful in almost all the dogs if there was a DLA matched puppy for the recipient dog. So that was the beginning of transplantation, hematopoietic cell transplantation, that you got to have a HLA compatible donor. But not only that, for that graft to survive, the graft needs to find its place. How can the graft find its place? I mean, I always give this analogy to patients that, look, for kidney transplantation, you have an organ which you can visualize, which you can anatomically remove, which you can anatomically suture. which you can move in your tray from one place to another. But what is bone marrow as an organ? It's just a conglomeration of cells. But when we are talking about transplanting those cells from one individual to the other, they have to have a place to reside. And that's what the bone marrow stroma or microenvironment is. And what Donald Thomas and the team showed at that time was that you need space in the bone marrow niche. In those microenvironments, you need space for the stem cells to reside. Now, if the bone marrow of the host or the patient is already populated with normal or disease cells, the donated or the grafted cells would find it difficult to find the space. And that was the reason they went for graded increase in dose of radiation until they found a perfect dose in dogs, which would help them to engraft. Now, when they said that, okay, fine, so we have found a solution that we need to give a certain dose of radiation, we need to find a DLA in dogs or HLA in humans, a HLA compatible donor. But what next? The next step was to figure out that what was described in my sort of alma mater, which is University of Birmingham by Bellingham and colleagues in the 1950s as runting disease in the mice, which is basically graft versus host disease. When they grafted mice, the mice, even if they were grafted, died weeks later from complete loss of, complete emaciation. So it was called runt disease. And the same thing was witnessed in dogs as well. So there came the use of immunosuppressants along with transplant, which we now call graft versus host disease prophylaxis. And in one of the few randomized studies which took place in the latter half of the decade, it was shown that cyclosporin with short course methotrexate that is given in pulses on day +1, day +3, day +6, and day +11, it helps in not only engraftment, but to prevent graft versus host disease. And that is still the gold standard of graft versus host disease prophylaxis in matched donor transplantation, cyclosporin and methotrexate. So with this, knowledge in their armamentarium, Donald Thomas and colleagues went on to go ahead and do clinical or human transplantation in patients of acute leukemia. And what you see over here is in 4 years, they had improved their survival. So that is the story of conditioning. Now, when we talk of conditioning, the backbone of any conditioning, or let me before backbone tell just a couple of things more. That conditioning, it was believed, was to create a niche or a space in the host bone marrow stroma or microenvironment. But that's one reason. The reason, which was obviously the majority of the diseases which were transplanted for at that time were acute leukemia. Not only acute leukemia, they were relapsed, they were refractory often. So those diseases needed to be treated before the cells could go and sit in the niche. So one of the reasons or one of the purposes for conditioning conceived was to have an anti-leukemia effect. And radiation was a perfect vehicle for anti-leukemia effect. At the same time, there were two other drugs which were being experimented with, both being alkylating agents. One was cyclophosphamide, which you all are too used to right now. So cyclophosphamide and busulfan both are sort of bifunctional alkylating agents, and cyclophosphamide was being used for other reasons at that time. So Donald Thomas combined cyclophosphamide with TBI, or total body irradiation, and started treating patients with leukemia. On the other hand, at Johns Hopkins and other centers, they started using another drug called busulfan, another alkylating agent. Now, with the use of busulfan and cyclophosphamide, engraftment of donor marrow was equally possible. And that was the beginning of conditioning, which still remains the gold standard for conditioning in allogenic transplantation, what we popularly call a CyTBI or BuCy. So that's in brief how it all started. And what you see in the table on the right-hand side is again a very interesting data from CIBMTR between 2009 and 2011, which shows you that how things had changed between that time. The number of times these agents have been used between this 2-year period. So that we'll discuss in course of this discussion. But I think that's all for the beginning. Over to you, Sarita.
Thank you for this elaborative explanation, and we really thank E.D. Thomas and the team to go through such a painful journey. So now, sir, what next question would be, sir, what changed the concept of conditioning from being a non-myeloablative to completely non-myeloablative? So the reason why I'm asking this question is that when all these were started, you were at a center of UK and developed several protocols in this regard. Your studies regarding reduced intensity conditioning transplantation is very much known to most of the students of transplantation. And if not, they should go back and revisit those studies. So over to you, Dr. Chakrabarti, to explain.
Yeah, thanks. At the heart of transplantation, allogenic transplantation, was myeloablation, as I said, to create space in the bone marrow stroma of the niche. That is, you have to irreversibly damage and kill the existing hematopoietic stem cells. So that was supposed to be a prerequisite for success of allogenic BMT. Along with that, why we use cyclophosphamide was that it was not myeloablative in a conventional sense, because cyclophosphamide, as you all know by now, does not kill the stem cells, but it provided the perfect immunosuppression. Now, for any foreign cell to engraft, even it be a HLA compatible cell to engraft, the host immune system has to be ablated. So in conditioning, there are two concepts: myeloablation and immune ablation. So based on this concept, any conditioning regimen is developed. In BuCy, myeloablation is provided by busulfan, and cyclophosphamide produces the immune ablation. And for CyTBI, both TBI and Cy provide immune ablation, and myeloablation is provided by TBI at above a certain dose. Now, the researchers at that time, the transplanters at that time in the 70s and the early 80s, were riding the high horse of myeloablation. And why I say this is because at that time, the whole energy was focused on uh, how we could augment or increase the intensity of conditioning. Now, the best tool they had in hand at that time was total body radiation. So a single dose of 10 gray was what it was started with. But subsequently, with fractionation of dose of radiation, a higher dose was possible to be delivered. 12, 14.4, and then it went up to 16. Now, what was found interestingly is that at that point, in patients who were treated with 16 gray of TBI along with the same dose of cyclophosphamide, the relapse rate was much lower, but so was survival. What it meant was that beyond a certain dose of cytotoxicity, the human body is unlikely to tolerate and survive. In order to kill leukemia, you will be ultimately killing the patient. So it was realized that there is a ceiling to what you can do with myeloablation. At the same time, there were several observations made in the course of these transplants by the Seattle group and then others. Number one, there was a publication where they showed that the patients who were developing graft versus host disease and surviving were having much lower rate of relapse than those who did not have graft versus host disease. Number one. Number two, they showed that those who were having syngeneic transplantation had higher incidence of relapse than those who were having a non-syngeneic sibling transplantation. So in other words, some degree of HLA incompatibility means that it need not be in major HLA, because when you're talking of a HLA matched sibling, they are obviously matched at the major histocompatibility complex, but they are often mismatched at the minor HLA antigens. So this mismatch is possibly necessary to provide a relapse-free survival. The question that was asked was how and why. And then came the study from John Goldman in patients with CML, where because to reduce graft versus host disease, they did T-cell depletion. And they found that with T-cell depletion, the relapse rate was very high. And that probably gave the answer that you need T-cells to provide a lower rate of relapse. And that also gave the concept of graft versus leukemia or graft versus tumor. And that graft versus tumor effect was believed to be generated by donor T cells. So with this concept that, look, conditioning is not the only way to, have an anti-leukemia effect. You can use the graft or the T cells in the graft to generate an anti-leukemia effect. The paradigm shift took place. The paradigm shifted in the early 90s with this study from Hansi Korb, where in patients who were relapsing after CML, I mean, this again were preclinical data derived from canine experiments, where they showed that if you use just donor leukocytes in, say, dogs who were relapsing after leukemia, you could actually, generate anti-leukemia effect and even put a dog into remission. They use the same principle and use donor leukocytes or simple buffy coat in patients of CML who had relapsed. And they found that a substantial number of patients would go into remission and they would remain in remission. And that firmly established the concept of immune-mediated killing of leukemia cells and the birth of bone marrow transplantation or hematopoietic cell transplantation as a form of cellular therapy. Now you hear the word cellular therapy repeatedly in every sphere of existence, that the cells can be, made into whatever you feel like. But the strongest form of, anti-leukemia effect is generated by an allogenic cellular therapy in the form of allogenic hematopoietic cell transplantation. So in 1998, when I was in the UK, I went with the pure purpose of, exploring the world of transplantation. I've been extremely excited having met Shimon Slavin a year earlier, where he had spoken about being able to kill leukemia in mice by splenocytes from donor mice, etc. And he was talking about that you can actually do transplants without causing this havoc by myeloablation. And in 1998, this was a conversation in 1995, and in 1998 he came up with his clinical paper, which was published in Blood in February 1998. I mean, that was, the excitement which the astronauts in NASA felt about going to the moon. I mean, we were just, getting baptized in this field, and to have a paradigm shift, have a complete change of concept at that time, and having had the opportunity to interact with the stalwart himself, even before he had put into clinical use, where he showed that combination of fludarabine, which was a newly introduced purine nucleoside analog used at that time for chronic lymphocytic leukemia, at a very tolerable dose, which was used in CLL, along with half the dose of oral busulfan and ATG, he achieved engraftment in 25 out of 26 patients, which was unthinkable at that time. And I cannot not mention that at the same time, in the same years, few months here and there, came out another game-changing publication from the Perugia group, Franco Aversa, who was authored this paper, which was the first successful haploidentical transplantation with CD34 selection. So that was, if you look at this slide carefully, Shimon Slavin uses fludarabine and low-dose busulfan with a little bit of ATG to achieve engraftment in matched sibling donors. On the other hand, the Perugia group is going in a complete immunoablation and myeloablation mode by using full-dose TBI, thiotepa, fludarabine, and ATG to achieve success in haploidentical transplantation. So these two extremes in terms of condition, into extreme form of donors, in 1998 set the platform for what we are doing today. 20 years later, the Johns Hopkins group combined the two, that non-myeloablative transplantation, combine it with the haploidentical donor, and achieve what we are knowing today as PTCY-based haploidentical transplantation. But I forever remain grateful to these two gentlemen, Shimon Slavin and Franco Aversa. Um, Franco being a very, very good friend and mentor to me even now. And I learned transplantation from these two geniuses. And the third one being Hansi Cole, who was a father of dear life. So what I'm talking to you today is being created out of an infusion of these three people in me. And what I'm conceiving, what I've conceived, what I've produced in the clinical field is simply a contribution of these three gentlemen, apart from, I keep on saying, Professor Tony O'Kill, who taught me, you know, how to do transplantation without any fear. So, at that time, it was all myeloablation, Psi 120 TBI 12 gray, Psi 120 TBI might be a bit lower, but BuPsi. So it was all about that until started by Shimon Slavin, the whole bandwagon of what we now call as non-myeloablative or reduced intensity transplantation came in. And there are any number of combinations which I can discuss later on, why one and why the other. But in a nutshell, if one has to talk about it, conceptually, a myeloablative conditioning is something that will cause an irreversible pancytopenia. That is, the stem cell pool will be eradicated. You wouldn't have stem cells left to repopulate the marrow. And to repopulate the marrow, you need a graft. A non-myeloablative conditioning, on the other hand, is a protocol which will cause minimal cytopenia. Something like, if you are using CHOP in conditioning, that is a non-myeloablative conditioning. If you are using BR in conditioning, that is a non-myeloablative conditioning. And anything which is not myeloablative, which is not non-myeloablative, used to be called reduced intensity transplantation. And if you are sort of in the field of transplantation and read about it here and there, you'll find people use various terms nowadays, that intensified myeloablative, reduced toxicity myeloablative, and so on and so forth. Now, these are all, what people conceive of as being able to use myeloablation without actually harming the host or patient too much. So if I am to summarize these three aspects of transplantation, the Seattle group led by Rainer Staub in the 1990s, and they started their studies in early 2000. They just used 2-grade TBI and later on added fludarabine to it with cyclosporin and mycophenolate as GVHD prophylaxis. And this resulted in uniform engraftment in matched sibling donor in patients of leukemia, lymphoma, or myeloma who were heavily pretreated. Fludarabine cyclophosphamide, a protocol which was popularized by the MD Anderson group in patients of lymphoma. In UK, what we had used that time was fludarabine and melphalan, which is not a non-myeloablative regimen, although it was touted as one at that time. And before long, we realized that, look, there are protocols which we are using which are not non-myeloablative, so they need a name. We called them lower intensity transplantation at that time. Subsequently, it was called a reduced intensity transplantation. And the popular ones amongst them are the use of busulfan at half the dose, triosulfan at a reduced dose, or any alkylating agent apart from cyclophosphamide, for example, being used at a reduced dose would be called a reduced intensity transplantation. So in that, this is a sort of working definition. What you call myeloablative and what you call non-myeloablative. Melphalan, any dose which is 140 or more is myeloablative. Thiotepa 10 or more is myeloablative. TBI, if you're using at a single gray, 5 to 6 grays and above is myeloablative. If it is fractionated, 8 grays taken as a cutoff. So these are working definitions which have been in use. Now, the only pure non-myeloablative protocols are something which has cyclophosphamide at a dose which is 120 or below. Why I'm saying 120 or below is cyclophosphamide by no stretch is myeloablative, but the myelosuppression it causes, if you use at a higher dose, is often very protracted, as has been seen in patients with severe aplastic anemia or even autoimmune diseases who were treated by 200 milligram per kilogram of cyclophosphamide. So to truly fit into the definition of non-myeloablative dose of cyclophosphamide, it has to be not more than 120. Say, for example, Ara-C. Ara-C is never a myeloablative drug because in the best of its ability, it cannot hit cells at T0. So Cytosar or Ara-C is a truly non-myeloablative drug. The same goes for anthracyclines, which have often been used in conditioning regimens, because their dose-limiting toxicity is not hematopoietic, it is cardiac. So you cannot exceed a certain dose, and within that dose, it's not non-myeloablative. The same way fludarabine is non-myeloablative. But one of the most classical non-myeloablative regimens apart from this has been the use of total lymphoid irradiation with ATG. I mean, if you ask me that, what would be a true non-myeloablative regimen, I would tell you that one is. That's a true non-myeloablative regimen because it does not touch the hematopoietic pool at all. It just takes care of the lymphoid pool, something similar to 2-grade TBI. Even, 2-grade TBI would still cause some degree of myelosuppression, but this one wouldn't. And and sort of when non-myeloablative regimens came in UK we used Campath, in Europe they used ATG, in US they used nothing. So addition of serotherapy became an integral part of non-myeloablative or reduced intensity transplantation in UK and Europe, but not so much in United States. So that is another discussion which we can have a chat later on. So over to you, Sarita. You are not audible.
Thank you, Dr. Chakrabarti, for this elaborative talk, and we at least understand. If now there is a question.
Sir, I guess she has network problem, but meanwhile there is one question from the panel, from the attendees, sir. What is the history behind establishment of beam conditioning? Why is the combination of drugs and how their dose has been identified? So this is from Dr. Akshay Lahoti.
Please remember it. We'll be talking about autologous transplants in shortly, okay?
Okay, fine, sir. Yeah, Dr. Sarita.
Yeah, this we will discuss during the autologous transplantation. So after understanding the various type of conditioning, now the next question would be, how do you decide who would get a reduced intensity or a myeloablative? Hello.
Yeah.
Whether
So
I think it is disconnecting.
see I think you know some of the people who have been unfortunate enough to withstand me for months or years is in the audience and would know that I always talk about three things: host, disease, and the treatment. The treatment in this case being transplant. So how you condition an individual would primarily depend on the host. When there was nothing other than myeloablative conditioning, the choice of transplantation, the choice of providing transplantation to someone was very limited. It was limited by age, it was limited by comorbidities, it was limited by gender. Now, if someone is beyond a certain age, we tend to soft pedal the treatment. But as we'll see later on, age is a number, and more than age, what is important is what is the condition of the patient? Does the patient have any comorbidities? If the patient has comorbidities, what I will use in my conditioning, will it affect the patient? Now, the whole point of conditioning is to get the graft in. I mean, you might get anti-leukemia effect on top of that, fine, absolutely fine. But what we do not want, and what often happens during the course of transplantation, because of conditioning, is something called regimen-related toxicity. And because of regimen-related toxicities, we get what we call non-relapse mortality or transplant-related mortality. And that is what we do not want. To eliminate that, we have to very, very carefully select a host. Now, a patient requires a transplantation. Is the patient fit for transplantation? If the patient is fit for transplantation, is the patient fit to receive a BuSci, Cy-TBI, Flu-Bu16, or at any TBI greater than 8 grade? So that's the next question that one has to ask. If it is not, then the next question is that is reducing the conditioning safe enough? It's not that by reducing the conditioning you are achieving a zero risk status. You might be reducing the risk to some extent, but that extent is limited when we are talking about reduced intensity conditioning. Then you have to think of the disease. Is it a malignant disease? Is it a non-malignant disease? Is the patient in CR or the patient is not in CR? If the patient is in CR1 versus CR greater than CR. See, each of these factors have an implication on the outcome. So even if a patient is in CR, is it a high-risk disease or it's not a high-risk disease? Is there CNS disease or is there not CNS disease? Means, do I have to give drugs to penetrate the blood-brain barrier or not? So these are the considerations that one has to have when one's considering the intensity of conditioning. The first or the primary consideration being the host, the second consideration being the disease or how you can manipulate the outcome through conditioning. The next factor would be the graft. Now, if one is using a T-cell depleted graft, then using a reduced intensity or non-myeloablative becomes very difficult in most times. So you have to conceive myeloablation with T-depleted graft. Now, why is that? Because There is nothing called non-myeloablative transplant. Okay. Now it might seem that I'm crazy, and this is an irony that why after all this I'm saying there is nothing called a non-myeloablative transplant, because a donor graft to get in and have a full chimerism in the host, of course there has to be myeloablation of the host. The difference being the myeloablation that's happening in the host in a non-myeloablative transplant means the drugs are not causing the myeloablation. It is the donor T cells which are causing the myeloablation. So the basic premise of engraftment is a graft versus host disease limited to the marrow. Now, this is a very, very primary or the basic thing in allogeneic transplantation, that to achieve an allogenic engraftment, one has to have graft versus host disease in the marrow. If you get it, you get engraftment, and at the same time, you generate an anti-leukemia effect. A bone marrow graft versus a PBSC graft. A PBSC graft is more likely to have successful engraftment in a non-myeloablative or a reduced intensity situation. If you're using a reduced intensity or non-myeloablative, you have to look at a higher cell dose. So these are the considerations with the graft that you have to take into account, which is in your hands, which you can manipulate. What you cannot manipulate is the patient. You cannot manipulate is the disease. So in allogeneic transplantation, you are given two constants and one variable. The two constants being the host and the disease, which you cannot alter in any way. But what you can alter is the graft. And what you can alter is how you condition the patient, what you use as GVHD prophylaxis. So in your hand, you have the graft, you have the conditioning, and the GVHD prophylaxis, which I often consider as one and the same. I mean, it is an integral part. So based on what you are considering for GVHD prophylaxis, what you're considering for graft, one has to consider what you will be using as conditioning. So it is, a dynamic interaction of these four factors, which one would then have to decide on what would be my conditioning. Now, there is not a single organ which the alkylating agents or the total body radiation would spare. Some more and some less. Some drugs affect the GI more, some drugs affect the liver more, some drugs cross the blood-brain barrier and put the CNS at risk. You know about bladder toxicity, hemorrhagic cystitis, and cardiac toxicity. Now, in that respect, mind you, with the use of PTCY, people thought that doing allogeneic transplant, haploidentical transplantation is now, damn easy. But in due course, a lot of people realized that it's not that easy, because at that dose of cyclophosphamide in heavily pre-treated patients, there is a high risk of cardiac toxicity, and bladder toxicity is universal. And some of you who follow the literature might know that at least we have at least offered a solution for hemorrhagic cystitis to the world. Cardiac toxicity, few and far, and it is unpredictable to a large extent. But with this respect of the cardiac toxicity, which I tell my students, is that the Western data cannot be transplanted into the Indian population. We are at a much greater risk of cardiac toxicity with a much lower dose of anthracyclines. If the dose for anthracycline is 550 milligram per meter square, touted by the Caucasian population, I consider a dose of 300 milligram to be the maximum that our patients can be given if they are going to receive cyclophosphamide or a transplant in due course, or if they have received cyclophosphamide along with the anthracyclines, etc. So that's one thing to remember. And the most important thing, especially in mismatched transplants, is the endothelial damage, which happens as a manifestation of alloreactivity aided and abated by the conditioning regimen. But when we are doing a transplant, we are all focused so much on the immediate effects, we often lose focus on the long-term toxicities. Because for us, the patient has to survive the first 100 days. The patient has to be cured of the leukemia. Patient has to survive for the first year. But mind you, the patients who survive would live for the next, if it's a child, would live for next 5-6 decades. If it's an adult, would live for next 3 decades. So we should be cognizant of the fact that these are the organs which we need to have in mind, especially when we are dealing with non-malignant diseases. The brain, the lung, the fertility, the endocrine. So with that, I think I have spoken about the basic premises or based on which you do select particular conditioning without going into the individual ones as such.
Once again, thank you, sir, for such an elaborative explanation. Now we will proceed moving ahead. What comes in my mind that what are the essential considerations when you decide conditioning between malignant and non-malignant diseases? In the same respect, there are two questions from the audience. One is from Dr. Radhika. What is conditioning regimen for pediatric acquired aplastic anemia for haplotransplantation, and how does it differ for congenital bone marrow failure and role of TBI in aplastic anemia transplantation? So over to you, sir.
And there is another question, I think, from
Yes.
Ranji Kumar.
Yeah, it's regarding the thalassemia, high-risk thalassemia in haplotransplantation, FTTA versus FBTA. Which one is your preferred choice as a conditioning? So these are the two questions.
I can figure out that T stands for triosulfan and busulfan in the other. Now, what is TA? What is, I can even imagine that one is thiotepa, one is triosulfan. Now, what is A? I don't know what is A.
I'll try to write.
If we mean the ATG, that's
thiotepa ATG. It's a thiotepa ATG.
Okay, got it. Now I need to get this off the thing. Okay. Malignant versus non-malignant. In some ways there is a difference. In some ways there isn't a difference. Okay. I would ask transplanters to look at thalassemia like an untreated CML, because no one anymore does CML transplant. We used to do a lot in those days. So thalassemia transplant is like a CML transplant. It's a bubbly marrow. It's a marrow which is pouring out cells like hell. It's a very hyperactive marrow. Okay. So a thalassemia transplant would be more like a CML transplant. Now, what is the difference between CML and acute leukemia in terms of allogenic transplantation? A patient of acute leukemia, say for example ALL or AML, whether they are in first CR or let's say relapsed AML or ALL, they have gone through rounds and rounds of chemotherapy. So their marrow reserve, their stem cell reserve is compromised. Their immune system has already taken a knock, especially in ALL, with multiple rounds of lymphoid-directed treatment. Whereas in CML, the marrow is virgin. It's just pouring out cells. And nothing has been done to suppress the immune system. So it's got an intact immune system, bubbly marrow. same as thalassemia. Thalassemia as an example of non-malignant transplant, sickle cell as an example of non-malignant transplant, and CML would be exactly the same. Now, what would be your major concern or consideration in these two diseases? The major concern is rejection because of an intact immune system and because of a completely untouched marrow. So in such situations, myeloablation, without myeloablation, there is a very, very high risk of relapse. And if you look at thalassemia transplants in those early days of 80s and 90s by the Lucarelli group, they used a lot of drugs to, myeloablate those patients. Very high doses of busulfan cyclophosphamide. And there was a lot of toxicity to those children, especially if they were, class 2 or 3 thalassemia, means their liver was already knackered. They were iron overloaded. So those are the children who would very poorly tolerate such regimens. So in due course, Lucarelli, being the great man he is, he realized that you just cannot, like the Seattle group realized in leukemia, you just cannot keep on increasing the dose of TBI and achieve an engraftment and cure. So there has to be another way. And Lucarelli came up with what was later called as preconditioning, where between 8 to 12 weeks of treatment with various agents to myelosuppress and immunosuppress without causing too much of upheaval in the system. Like he used hydroxyurea as a thioprin for 12 weeks in these patients who were class 3 thalassemia, who were older, a lot of marrow reserve, along with hypertransfusing them. Now, what was hypertransfusion achieving at that time? Hypertransfusion was done to suppress the inherent marrow. A beautiful concept, Just look at it, that he is suppressing the host marrow in thalassemia by hypertransfusing, keeping a hemoglobin at 14. So the bone marrow production would come down. And you are also hitting it with whatever as a thioprin, hydroxyurea. And he's bringing the counts down, giving GCSF, again bringing the counts down. So like doing a sort of a mini chemotherapy without troubling too much. And with that, he showed that in patients with class 3 thalassemia and older patients with thalassemia, he could reduce the non-relapse mortality by 20% and improve the results by 20%. So from 50%, the survival in those patients went up to 70, 80%. So that's how transplant is developed. You have to think out of the box. You cannot have an uniform thinking that, look, BUSI and TBI, that's all they have at that time. And mind you, TBI was also used for non-malignant diseases, thalassemia, aplastic anemia. Every disease TBI has been tried, but there's been a huge worry about using TBI in children because of the risk of cognitive brain damage, the fertility, the endocrine functions in the long term. Because when you are doing a transplant in a non-malignant disease in a child, it's not just about achieving engraftment. It's about what is going to happen to that child 10 years, 20 years, 30 years down the line. So those are the important considerations. In non-malignant disease, rejection is high on the ladder of your concerns or considerations. Whereas in malignant disease, you are not so much worried about the rejection because the patient is heavily pretreated. If it is not a fresh CML or a fresh MDS, in that case, the cure of the leukemia is of a bigger concern. And all of these, what I talked about, they are all intercalated. They're intercalated like the strands of DNA intercalated with who is your donor, what sort of donor, is that donor HLA matched, is it a one antigen mismatch, it's an unrelated donor who is fully matched, is it a 10 out of 10 match, 12 out of 12 match, is it a haploidentical transplant, what sort of haploidentical donor do you have, is it a marrow, is it a PBSC, are you going to manipulate the graft? So conditioning is dependent on all these factors taken together. You decide the conditioning. You don't decide the conditioning at the outset. You decide all the other factors, and then you decide on the conditioning. And this is sort of a very nice graph, which I sort of find very useful to show it to people, show it to students, show it to patients, that when you are using something like this over here, when you are using just TBI in a malignant disease, your toxicity is almost nil. Or you are using TBI and fludarabine, your low dose busulfan fludarabine, so your toxicity is very low. Your intensity of conditioning is very low. But what you have to compensate by is increasing the graft versus tumor effect. Whereas if you go to this most, horrendous combination, busi and TBI, you would possibly have generated a lot of anti-leukemia effect, a lot of anti-thalassemia effect, but at the cost of humongous toxicity. So it's a matter of balancing. So how do you achieve the balance is what you gain with your experience and the expertise you gain with training in transplantation over a period of time. And that's why I encourage young doctors who are passing out doing a DM or DNB to work under some mentor and not just go as lone wolf somewhere in a private hospital and start a transplant program, because that's not how it's done. Even after some 30 odd years, I think I know very little of this subject, very little of this discipline, because how one would react to you is not the same as the next patient, how it's going to react. And that I'll come to later on. So it is a constant learning process, and to understand or do, mind you, a lot of you are hematologists over here training as hematologists or trained as hematologists, but hematology has very little to do with transplant. Transplantation is immunology, pharmacology, infectious disease, critical care. These four things. Hematology and oncology are only the indications. So with that, I rest my case for now. And I have to be quick, I believe. So
yeah. Thank you once again, sir. So next question. So I understand these were mostly about the allogenic transplantation. So the people must be inquiring about the autologous transplantation. So my next question would be, what are the differences in conditioning between autologous and allogenic transplantation? In this same respect, there is one question that from Dr. Akshay about the beam conditioning. So over to you, Dr. Chakrabarti.
see, autologous transplantation was conceived more or less at the same time as allogenic transplantation. And bone marrow was a source of graft at that time. So there used to be a lot of poor engraftment in autologous transplants in those days. Because these were, this is just two sides of the coin. In allogenic transplantation, if your patient is heavily pre-treated, you engraft much more easily. But when you try to collect stem cells, bone marrow, that time CD34 counts were not even there. So bone marrow TNC was the only measure of what you're collecting. So you are collecting bone marrow from a heavily pre-treated patient, whether it's lymphoma, myeloma, leukemia, whatever. the graft is of a suboptimal quality and more difficult to engraft or have sustained proper counts, even in autologous setting. It was not until that PBSC came into, what we take as commonplace today, it was in the early 90s, that PBSC became a practice with much ado, that autologous transplantation became so much more easy and feasible than it was at that time. And mind you, what you see over here is that if you just go by stratify by age, there is a huge increase in autologous transplantation in older population over a period of time, as has been for allogenic as well. But what is the basic difference between autologous and allogenic transplantation? In allogenic transplantation, as we have seen, that you are generating graft versus tumor effect from the graft itself. The graft-derived T cells, the graft-derived NK cells, the graft-derived NK T cells, the graft-derived gamma delta cells. There are various sources from which we derive graft versus tumor effect. Whereas in autologous transplant, by conventional thinking, it was often in the domain of the oncologists who used to call it a high-dose chemotherapy. It's a high-dose chemotherapy, and melphalan-based myeloma transplantation is often called as high-dose chemotherapy with autologous stem cell rescue. That's the other name for autologous transplant, as we are calling it today. So in autologous transplantation, the combination of drugs which are used are often different from an allogenic transplantation, because you do not require immunosuppression as such unless you are doing an autologous transplantation for an autoimmune disease, which is a completely different ballgame. So let's talk of beam conditioning, how it came about. Tony Goldstone from University College London, I think they designed this protocol in the 80s and became very popular in UK and Europe, whereas in US they used different protocols. Say, for example, the beam protocol is BCNU, etoposide, Ara-C, and melphalan. And between the first dose of BCNU and the last dose of melphalan, you have Ara-C and etoposide. When you are using two alkylating agents, now alkylating agents, almost all of them, they deplete glutathione, and their metabolism is dependent on GST, or glutathionase transferase. Quite a few of them. Definitely both of BCNU and melphalan and busulfan and triosulfan. So when you are using one drug which would go down the glutathione pathway and be metabolized by cytochrome P450 pathway, giving another drug at high dose immediately afterwards would cause pretty heavy toxicity. So that's a basic principle of conditioning with alkylating agents, that you have to space out these two drugs. Now, when BCNU and melphalan were being, distributed in the timeline of conditioning, it was seen that it's best because, people in UK are more conservative than in US. I mean, you will see the US protocols where they have used similar drugs. They have used BCNU at a higher dose. They have used much higher doses of cyclophosphamide. They have used 3 or 4 alkylating agents together. But the beauty of BEAM protocol is this, that the BCNU is being used at 300 milligram per meter square. It has been used as high as 500 milligram per meter square. The UK protocol is 300 milligram per meter square, and melphalan at 140 milligram per meter square, which is a dose limiting or maximum tolerated dose, let's put it this way, maximum tolerated dose. There are two things you have to remember when we are talking about these drugs: maximum tolerated dose and dose limiting toxicity. So when you are using melphalan alone, 200 milligram is a maximum tolerated dose. Now, the dose limiting toxicity for 200 milligram melphalan is not myeloablation. When you are doing a transplant, myeloablation is not a limiting toxicity. It's a desired effect of the drug. So the dose limiting toxicity is GI toxicity for melphalan, liver toxicity for busulfan, CNS toxicity for busulfan, cardiac toxicity for cyclophosphamide, so on and so forth. So these are dose limiting toxicities. So BCNU, the dose limiting toxicity is when you combine with another alkylating agent is liver toxicity or BOD. And also in BCNU, in the intermediate and long-term, lung damage is a real toxicity. So using BCNU and busulfan together would increase the lung toxicity, mind you, because both are toxic to the lungs. Both cross the blood-brain barrier. So combining BCNU and busulfan is never a welcome combination. So what was done with BEAM was to space out melphalan and BCNU. Two other non-alkylating agents were introduced because they were part of the salvage protocols, cytarabine and etoposide. And instead of using a high dose of etoposide or a high dose of cytarabine, transplanters, what they did was they used repeated low doses. That means over 4 days you give lower doses of cytarabine and etoposide. Being that way has been found to be very useful in Hodgkin's, more than non-Hodgkin's, number one, and it is a protocol with very little toxicity. That has been the beauty of it. That's why people across the board have, used it, for people even at the age of 60, 65, whatever. So BEAM is a reduced intensity autologous protocol, you can call it. And as I told you that I don't believe that you need to go overboard with any drug in conditioning to achieve the maximum anti-tumor effect. Even in autologous transplantation, you can and you should be able to generate an anti-tumor effect. How and when is not within the scope of this discussion, but mind you, the aim of a conditioning regimen is to achieve in autologous transplant the maximum anti-tumor effect without maiming, without harming the patient. And BEAM is one perfect example of that. Now in myeloma, there are, melphalan 200 is melphalan 200. That's the maximum you can do. People have used various combinations of other drugs along with that. And at the end of the day, whatever you do, unlike being in lymphoma, you are not curing the patient of myeloma with adding X, Y, Z. So that is pretty moot or futile in my mind. But to cut the long story short, I hope I've conveyed to you why how BEAM was designed, what's the principle of generating a high-dose chemotherapy protocol, particularly when you're combining alkylating agents. Say, for example, cisplatin is not used in, pediatric solid tumor conditioning regimens. Now, hematopoietic toxicity is never a concern. So, its maximum tolerated dose is totally dependent on its toxicity on the CNS, on the kidneys. So the platinum group of drugs, they're used a lot in such transplants. So the way of using them is very different than you would use a drug which is predominantly hematopoietic toxicity or GI toxicity. So I think that answers some of the questions.
Yeah, So I still remember in day-to-day our clinical practice, Dr. Chakrabarti says to us that it's the cell which will kill the cell. It's not the conditioning, or it's not a conglomeration of drug which will sufficient to kill your disease and to achieve a maximum anti-leukemic effect. Now, sir, I'll move ahead to and will proceed to some of the special condition like obese or the older patient. I know very few people do transplantation in these obese patient in India. However, when I was there in Seattle in 13, 14, the transplantation above the age of 70 was routine. And you have also transplanted patients up to the age of 65. So my question would be, what are the consideration for patients who are older age, and similarly patients with comorbidities, or like the having the renal diseases or the hepatic diseases? What should be the differences in choosing the weapons of conditioning? Over to you, sir.
Yeah, thanks, Sarita. I'm sort of getting a bit tired, so I'll be a bit quick. See, the thing is, again, this, I think this is CIBMTR or ABMT, I don't remember. It shows that simply for the above the age of 50 years, the red boxes, the green boxes, they are basically increasing over a period of time. That's more, the more older patients are being transplanted with reduced intensity conditioning nowadays. And it's true for all diseases. I mean, maybe more true for some than others, but it's true for all diseases. Now, several people, particularly in AML MDS, where in West the median age of onset is say 65 or 70 years, that what is the outcome of allogenic transplantation, particularly matched allogenic transplantation based on age? And in this particular paper, what you see, this is a CIBMTR paper, that 40 to 55, 55 to 59, 60 to 64, 65 plus. There is no difference in RM or relapse. So really, based on age, numerical age, you cannot say that, the outcome is going to be poor. I mean, the disease-free survival, the overall survival, MDS, AML is exactly the same. Now, what then dictates the outcome of a transplantation? And at the same time, I show you our data on haploidentical transplantation in 125 patients. So this is the data up to 2020, where we show that patients, of course, who were between the age of less than 20, 20 to 40, they had 75 to 80% survival. But those who were between the ages of 40 to 55 and 56 to 65, they're not a small number. I think it's 25, if I'm not mistaken. 25 patients who had a similar survival, I mean, in statistical terms. And mind you, these were patients who had very advanced diseases. Otherwise, we wouldn't be transplanting them at that age. So even in our hands, we have seen similar figures that if you carefully select the patients, select the conditioning, select the type of transplant, you can have good results. Now, what other considerations based on age? HCTCI is something that one has to be very cognizant with, because it has been clearly shown that the more comorbidities one has, the higher the risk of non-relapse mortality. And at the same time, the disease risk index. Mind you, you don't do a transplant just for the sake of doing it. If you are doing a reduced intensity transplantation or a non-myeloablative transplantation because if someone has a high comorbidity, if the disease risk index is high, does it really justify doing that sort of transplant? Do you think you'll be able to generate enough anti-leukemia effect to cure this individual, or just putting the patient through for nothing. The other very important thing in old age is the frailty index, which I would encourage everyone, because again, it's not within the scope of this presentation. Frailty index is calculated in various manners, and it's a very good indicator of outcome irrespective of age. And resiliency is another factor which is often considered in the equation when we are counseling or considering older patients for transplantation. And I mean, it's not a surprise that this is again data from Seattle, which shows that the 100-day mortality is highest when you are using myeloablative transplant conditioning with TBI. But when you do not have TBI in myeloablative conditioning, the 100-day mortality is not significantly higher, although it's high. And it's reflected in non-relapse mortality, where you see that, even in these patients, even in patients with RIC, the mortality, non-relapse mortality is high. And this increase in mortality is not just based on age. This mortality is based on BMI or obesity of the patient. Now, there are two things when you are considering the weight of the patient. Patients who are too thin have a high mortality, and patients who are too fat also have high mortality. That's true for most of the conditioning regimens, most of the type of transplants that you do. So it's very important to consider, along with the age, the weight of the patient, and particularly the obesity. Now, if the patient is very thin and emaciated, that by itself is a poor prognostic factor. But being overweight, having a BMI in excess of 30 and in excess of 35 is also a very poor prognostic factor. So how do we go about it? This is, again, a recommendation which you'll find in the ASPMT guidelines. But what I'll tell you what we do over here. What we do is we cap the body surface area at 2. And if even after capping at 2, we see that the patient is very short and very obese, which is putting the body surface area to a huge extent, we take the ideal body weight. Now, what do you do with the ideal body weight? Do you take just the ideal body weight, or do you do something more than that? So there are different ways of doing it. You do take the total body weight minus the ideal body weight, and that number, you take a percentage of it. It might be 25%, it might be 40%. So some drugs to be dosed based on total body weight, but some drugs which are lipophilic, which will be sitting in your body fat, has to be dosed differently. But by and large, we prefer dosing based on ideal body weight plus 25% of the difference. Or if it is a patient who is, by the dint of its height, would qualify for a body surface area of 2 or above, we cap it at 2. Now, the other important consideration in, when you talked about special consideration, is the GFR. Now, if the GFR is low, less than 45, the mortality, the overall outcome has been found to be poorer. There are different recommendations for different agents to be modified based on the GFR, but by and large, in a patient who's got a GFR less than 45 or 50, one has to be cautious in taking a call for a transplant. And finally, when we are talking of all the toxicities, for some, we have some weapons in our hands. Defibrotide, exquisitely expensive, but if there is a risk of POD, one might consider it as prophylaxis rather than treatment. We use NAC a lot in terms of preventing transplant toxicity. Mesna we have used in a particular way to prevent bladder toxicity. You can look it up. Cryotherapy is often used with melphalan to reduce GI toxicity, and fertility preservation in young patients is an absolute must in today's day and age. So over to you, Sarita.
Yeah, thank you, sir. So we have reached to the last question, although the question will be there, and there is one more question we will answer later, but I would request, I have seen people are following the just transplantation conditioning, which are designed by the West and gone through the several studies like BUSI, size, TBI, and other reduced intensity conditioning at the same time. So you have designed, I have seen so many conditioning protocol by yourself. So for the benefit of young transplanters or the people who inspired to do differently in the field of transplantation, would you elaborate your special thoughts to design a conditioning protocol for all of us? Thank you, sir.
Okay, I'll try to quickly go through it, as I think it's been a long time. I will first start by, I'll just take this opportunity to show the young guys how you can be misled by publications, okay? Now read this heading. I mean, conditioning intensity in acute myeloid leukemia with poor prognostic cytogenetics in first complete remission. Right? This is a study from Japan. Now they show that MAC is better than RIC in poor prognostic cytogenetic group, myeloid leukemia, who are in first complete remission, right? No doubt about it. MAC is better than RIC in patients with poor risk cytogenetics. Now this is a study from, CIBMTR study from US, where they show that in low and intermediate risk, MAC or myeloablative conditioning is better than RIC. But when it comes to poor prognosis cytogenetics, there is no difference. Now, tell me, which one would you believe? Which one would you choose? Because we blindly follow the literature, we blindly follow the West. So you will say that, okay, fine, RIC or MAC doesn't make a difference in poor cytogenetic group. So I would use non-myeloablative transplantation for all damn high cytogenetic risk group and use MAC for all low risk patients. Does it make sense? So that's a conundrum of whether to use TBI or not to use TBI. A classic, teaching is that in AML, BUSI, particularly IV BUSI, is better than TBI. For ALL, TBI is better than non-TBI. But I mean, as I said, I don't have time, I don't have the energy anymore. But if you go deep into the literature, you will find everything to the contrary as well. But again, it's believed as a rule of thumb that BU-based conditioning is better for AML, TBI for ALL. So right now, we have two groups of drugs to play around with in terms of conditioning, apart from TBI. One group of drug are alkylating agent, the other group of drugs are nucleoside analogs, right? So you are given a piece of paper and you are given some alphabets, you have to work on it. The alphabets are, F for fludarabine, and B for busulfan, C for cyclophosphamide, B for BCNU, then M for melphalan, and T for triosulfan. So you have to mix and match them, and T for thiotepa. So you have to mix and match them to achieve what you can best achieve. So on the bottom one over here, what you see is that how busulfan and cyclophosphamide are metabolized. And unless you understand these things, it's best not to try to go into altering any conditioning protocols. So busulfan is metabolized by GST, and it generates glutathione sulfonium ion. Cytochrome P450 is what metabolizes cyclophosphamide to generate, this is the active metabolite. and glutathione detoxifies both of them. Okay, and cytochrome P450 would render the busulfan inactive. Cytochrome P450, on the other hand, renders cyclophosphamide active. And glutathione is detoxifying both of them. Fine. So these are the basic principles. Try to understand. So if you are combining busulfan and cyclophosphamide, what should be the optimum dose? Those have been talked about a lot in the past. So busulfan 16 milligram per kilogram oral, or 13.2 milligram per kg when you're giving IV. Cyclophosphamide 120 milligram as a cap when you're combining. So that's fine. Cyclophosphamide you give over 2 days, you give over 4 days, that's your choice. Busulfan you give over 4 days if you are giving it as a myeloablative conditioning. And let's talk about myeloablative conditioning right now. So if you're combining Bu and Psi or any two agents, what would be the sequence of the two agents is very important. And I'm taking the example of Bu and Psi. So mind you, cytochrome P450 would activate Psi and would deactivate Bu. Okay. So the traditional use has been busulfan followed by cyclophosphamide. So busulfan uses up glutathione and you use cyclophosphamide thereafter. And cyclophosphamide detoxification might be an issue unless you know that and you give enough gap between these two agents. Or even better is if you use cyclophosphamide before busulfan, because cytochrome P450 is needed to activate cyclophosphamide. So the enzyme needed to use cyclophosphamide, use it first. It gets detoxified in the same pathway, and then give at least 40 to 72 hours gap and use busulfan. Now, the second and even more important consideration when you are using myelotoxic drugs is what should be the gap between the last dose of your myelotoxic drug and the cell infusion. That would depend on the terminal half-life of the drug. And basically terminal half-life into 7 is what would, for how long it would remain in the circulation. And you have to give a leeway or give an allowance for another several hours for it to clear. For example, melphalan has got a T-half of a few minutes, and it would be cleared from the system within a few hours. But even then, we do not infuse cells 24 hours before the last dose of melphalan. So that's a diktat which we follow in transplantation, that we cannot risk the graft. So unless you have a very thorough knowledge about these things, it's best not to tinker with a protocol, because otherwise you'll land up in trouble. Now, the nucleoside analogs, on the other hand, now these bifunctional alkylating agents, they would bind to the DNA, they would damage the DNA. What these nucleoside analogs, fludarabine and cladribine, they do is that they not only cause apoptosis of the cells, they actually cause histone modification, and they expose the cells to alkylating agent induced damage. So in other words, they are priming the cells for being killed by alkylating agents. So that is where again the timing between fludarabine and busulfan or cyclophosphamide or triosulfan is very important, how you time these two drugs in the conditioning protocol. So use it blindly doesn't make any sense. And mind you, the fludarabine and gemcitabine, clofarabine, all these agents and nucleoside analogs, they need transporters to get into cells which alkylating stone. And they need to be metabolized by several kinases into the active form, which they don't. So that also has to be a consideration. So because unless you have this pathway, these agents are pretty ineffective. That's why in certain situations, and even now, cyclophosphamide is a better immunosuppressive drug than fludarabine. So I think I have explained the basics of it in this short time. And this is a whole list of drugs with their, different maximum tolerated dosages, whether you use it in combination or whether you use it as a single agent. If you are using TBI, what should be the fractionation? These are all decided. What is the maximum tolerated dose alone or in combination? These are decided. How you use them, in what combination, in what sequence, in what timeline, is what you decide when you're designing those protocols. And Uday Popart's one very elegant protocol I will just show you if you do not know about it, that he found that using busulfan at one go, especially in older people, was more toxic. So he distributed in a weekly manner, day minus 20, day minus 13, and then during conditioning at a lower dose. And this is a beautiful concept, which we have, I cannot go into the details, which we have also employed in certain situations. But I found this concept absolutely elegant, that conditioning, giving at one go, is might be toxic. And this is combining the concept of Lucarelli's precondition with a conventional conditioning. So what you call it is a protracted conditioning or a long conditioning. So finally, I would end by saying that cytotoxics, alkylating agents, nucleoside analogs, and TBI remain with us as the mainstay of conditioning, along with serotherapy. But use of total marrow irradiation or total lymphoid irradiation, or more interestingly and importantly, anti-CD45 or anti-CD117 monoclonal antibodies, which are either toxin conjugated or radioisotope conjugated, would be something we would look forward to actually achieve myeloablation without causing organ toxicity. And another idea that is purely my idea at the moment is using an anti-CD117, CD45 CAR with a suicide gene. That would be the most neat form of doing allogenic transplantation. And so thank you, everyone. I will take up